So Larry, you and I have been around the world teaching clinical trainings for working with trauma, and you've been doing this for many years. And both of us have talked about this real growing hunger for working with complex trauma and learning approaches and skills that are going to really address the complexity of working with attachment, relational, and developmental trauma. Mm-hmm. And you've created what I feel is a brilliant model, the NeuroAffective Relational Model. And I wonder if we could just give viewers a little bit of flavor or sense of the basic clinical skills of NARM, which you refer to as the 4 pillars of NARM.
Yeah, I'd be happy to, Brad. Thank you. As the viewer can see, that we've got the 4 pillars up on the screen, and the very first one is called clarifying the therapeutic contract. We have contract in quotes because we use the word contract differently than it's used in some other therapeutic models, but we use it differently than in any model that I know of anyway, and certainly differently than is understood in the world. Now, in the training, I talk about what the importance of clarifying the therapeutic contract is that the first step is the client setting the intention, what it is that they want. And we do it in a particular way that it doesn't even have to be realistic. The important point is really energetic and emotional, that the energy for the work itself comes from the client. Mm. And I want to share with viewers what I see so often. I do supervisions in many different countries that I teach in, and I see this pattern again and again, where a client comes in, complains about certain symptoms, physiological symptoms, psychological symptoms, and the therapist then immediately jumps in and starts trying to help and to fix. Mm-hmm. And they then take the responsibility on their shoulders, the therapist I'm talking about, the therapist takes the responsibility on their shoulders to come up with a plan, to fix, all of this kind of efforting that, from my perspective, from a NARM perspective, really gets in the way of an effective clinical experience and of effective clinical skills. So that the very first step, as it shows there, is establishing the contract. The client sets the intention. They say basically what it is that they would most like, what they want from their work together. And then if the therapist agrees that that's something that they feel comfortable themselves working with, then they reframe this goal-oriented declaration on the part of the client into an exploration-oriented contract. So, for example, this can be used again in all different kinds of work. And so a simple example would be, and this is based, over the years, I've had a number of people who had either this kind of dynamic or something similar, where someone would come in and say, I've been stuck writing my dissertation and I've been working on it for 4 or 5 years and I can't seem to finish it. I really need, and they might say, I've heard it said different ways, I need somebody to give me a kick in the butt to get me going, or I need a real good plan to help me complete it. And I would not accept either of those as a contract. They're saying that they want to finish their dissertation. That may or may not be true, but that's their stated intention. And then I will reframe that, and I said, I will be glad to explore with you what gets in the way, or what is getting in the way of you finishing your dissertation. Mm. Now, that point about exploring what's getting in the way, we use that a fair amount, but not all the time in terms of the contracting. It depends on what it is that they're really wanting. Now, for example, if somebody comes in and says, I've been struggling with depression for the past year, the contract would be more open-ended. Well, I'll be glad to explore what this depression is about. And that's
more general in that sense.
Sorry?
More general in that sense.
Yeah, more general. So it depends on what it is that the client is most wanting. The one thing that we don't accept as a therapeutic contract is just to focus on a symptom. Now, it's natural that clients want symptom relief. That goes without saying. But I want to help them understand, if we're talking about, particularly something that is being psychologically driven, emotionally driven in some way, not to just fix the symptom without addressing what it is that's driving the symptom. For one thing, often symptom reduction or symptom relief is a recipe for frustration for both the therapist and disappointment for both the therapist and the client, because it often isn't addressing what is really the core issue that's involved. So for example, with this example that I just gave you about the dissertation, I will very clearly tell the person, well, I am not here to give anybody a kick in the butt, and I'm not here to create a plan for you to accomplish what it is that you're saying you want to accomplish, but I will explore what's getting in the way of that. That keeps it much more open. If we say I'll help you develop a plan, we're assuming that there is no internal conflict within the client about finishing. And that's not an assumption that I'm willing to make. There may or may not be. Maybe there's practical things that will come out as we go, into the second pillar and start asking exploratory questions. But we're always leaving open the possibility that really the symptom is about some kind of intrapsychic conflict. And that's what I want to explore with the client. What is getting in the way, not just on a practical level, but really primarily on an emotional level? What's getting in the way of you finishing? And
so Larry, in this example with the person that's coming in that's wanting you to give them a kick in the butt to finish your dissertation, we might be holding open the possibility that there's part of them at least that actually doesn't want to complete the dissertation.
that's a good clarification, Brett. Thank you, because that's exactly what I mean by intrapsychic conflict, that they're not finishing because there's really a part of them that, for whatever variety of reasons, really doesn't want to finish, or finishing has some kind of negative meaning or implications for them that we don't want to ignore by just creating a goal-oriented kind of process. So that's why first the client sets the intention, and then we agree to explore whatever the dynamics are. And they could be emotional, behavioral, cognitive, a variety of dynamics that are getting in the way of them completing.
And that's the second pillar that you're referring to now, the asking exploratory questions, doing the inquiry into the dynamics that might be part of that intrapsychic conflict that you've kind of framed through the first pillar, the contract.
Exactly. And so if we don't have the right contract, like a useful understanding about what we're doing, then as I said, the therapist gets into trying to fix it, and gets goal-oriented, which brings frustration, all of this dynamic. And we can't promise, every clinician knows that we cannot promise results.
Yeah.
One of the things that we can promise, though, is that we will explore with the client what the problem is, or what's getting in the way of them having what it is that they're saying that they want, even as you point out, that it may be that really the biggest part of them doesn't want to finish. And I don't personally take a position. I don't believe that everybody who starts a dissertation should absolutely finish that if that's not right for them. I don't make those decisions for my clients. I leave that up to them as part of the exploration, as they explore the various aspects of what is likely to be some kind of internal conflict. Then they ultimately decide what they want to do for themselves. In one case, sorry?
I was going to say that sounds like now you're moving into the third pillar, which is really helping the client make contact with their sense of agency that might be working unconsciously in that intrapsychic conflict.
Yeah, that's exactly right. And we'll see that these four clinical pillars actually hang together, so that by having the client set the intention and then working out an agreement or an understanding, or as we say, a contract in quotes, as you work that out together, you're actually supporting the agency of the client. You're not taking over functions, as we call it, by trying to fix them or make everything better. You're going to be part of a process with the client of exploration, trusting that as you explore the various dynamics, that they will find their own solutions.
Yeah, which is a critical piece, because again, we're working within the framework of childhood trauma, and as adults, we don't fully make it into adulthood without some of our child still hanging on. And as you refer to it in the book, Healing Developmental Trauma, using these survival strategies, survival styles. And so the reinforcing agency pillar is really about bringing our adults back more online.
It is. It's like this third point is that we all play some kind of part in the various kinds of emotional struggles that we have as adults. It's not just something that happens to us.
Yeah.
And that we look at that, we use that dynamic across the board. So, for example, people will talk about, well, they're suffering from burnout. So, very common. It's a very common theme in Europe, but it comes up a lot in the United States as well. And burnout's just a word. What we want to see, and part of the reinforcing agency piece that you're mentioning, is there's a whole languaging that we teach people of what kind of clinical languaging can the therapist use that supports agency. And I'll give just a very brief example about that. Is like, so instead of that they are suffering from burnout, again, we have to be tactful about how we put this, because we don't want clients to feel blame. But we, at some point, want to communicate to them, what is it that you're doing or not doing that you're burning yourself out in the way that you're describing? All of the various symptoms of, fatigue and depression, anxiety, whatever the symptoms that go with whatever they're calling burnout. And we'll see that burnout isn't something that just happens. It's something that people do to themselves. And we never push that in a blaming way. Of course, we want to be people blame and shame themselves enough. We don't want the therapeutic process to reinforce that. But that's different from helping them see their part in it. And if they start to blame themselves when they see their part, that's something that we need to explore with them and help really uncouple, because blaming and taking responsibility or taking agency are two opposite. Blaming yourself and taking agency are two opposite ends of the spectrum.
Yeah, it makes me think of all the couples work, and when you're working with couples who are able to shift out of the blame shame game and into really owning their role and the relational challenges that they have, that's where success really can happen in couples work.
Yeah, in couples work, it's unless if the one member or both members of the couple are stuck into seeing themselves as victims of the other and blaming and the whole dynamic that goes on, not seeing their part, then the prognosis is not usually very good for that couple.
Yeah. So the last pillar here then, Larry, is about the reflecting positive shifts. And can you talk a little bit about how that wraps these 4 pillars together?
Yeah, it seems like a very simple thing. And yet it's such an important clinical dynamic, because it reflects, when you see positive shifts, and that could be increased understanding, more relaxation in the body, more connection to their emotions, whatever positive shift that they're experiencing, to have that reflected is actually supporting a healing process in a way that is often not done in therapy, by specifically addressing it, reflecting it, and bringing the client's awareness to the positive shift, and also what we talk about in NARM as deconstructing. What are the elements that are going into this positive shift? Whatever they might be for any given individual.
And, in terms of why that's important kind of on a physiological level or a somatic level, what do you think might be that skill or that pillar helping?
Well, so often we'll see as clinicians, at least clinicians who are used to paying attention to the body, we'll see that that's where any kind of increased insight or what we talk about in NARM as, increasing process of disidentification or coming out of old patterns, old survival styles, is it will almost always be visible in the body for those therapists who pay attention. And then when we see that positive shift, we see the shoulders go down, we see the breathing starting to get more regular, a whole variety of autonomic and other kinds of shifts that are actually visible, that anchors whatever the positive shift is, whatever level of experience, it anchors it into the body and into the general felt sense. And that's very, very useful. It makes, let's say, an insight, not just a disconnected cognitive response, but really a whole body knowing that I think most people have experienced. We can know something in our head, but when we know it in our bones and in our cells, that's when change happens.
Yeah, and it's exciting for clients to actually feel the change happening, as opposed to just understanding it or thinking about it, but to actually feel the shifts happening, in the moments is really powerful. And then I think there's something about reinforcing it and reflecting it back to the client that relationally is an important piece of it too.
Absolutely. I know we're coming close to our time here, but I want to go back just for a moment back to the second pillar, asking exploratory questions, because there's some important information. One of the things that we don't do in NARM is interpret. We ask questions. We invite the client to reflect on their own internal experience. But we don't tell them what they're feeling. We don't talk about defenses. We don't talk about resistance in NARM. And that shifts much of the therapeutic dynamic. It's like the therapist's expertise is in helping the client become an expert in their own internal world, not that the therapist is the expert in the client's internal world. Our expertise is just asking very useful questions.
Yeah, that's a great point. Thanks for adding that. So, we just wanted to give folks a little flavor of the 4 clinical skills of NARM. And for those of you that might be interested in doing further training in NARM, we have trainings that are beginning in Europe, in North America, and have some more books that are on their way. So please watch out. And we have more videos that will be coming as well. So thanks, Larry, for your time.
Yeah. Well, thanks, Brian.